Hello again. Welcome to another EMS Grand Rounds production. I wanted to talk this evening. This is a talk I've been given for a little while. One of the early ones that I kind of wrote in my medical career. This one on naloxone. And certainly anybody who's been in EMS for any length of time has had their hands on this stuff. You might ask a little bit about it, though. It's so prevalent. Are we doing something right with it? Do we need to give it, or should we be giving it? What about the stuff that causes you to give naloxone in the first place? What's with this opiate overdose epidemic? What is going on here? I wanted to delve into some of those things. So this is technically about naloxone, but also about some of the other things that go along with it, such as how do we properly manage an overdose? What are the things we should be doing? What are the things that we've always heard we should be doing, but maybe we don't need to? I want to talk about some of that stuff. So, first, good morning again. And as with most EMS Grand Rounds things, I want to bring up some sort of case before. And this one is best seen in this video, I think.
Get the hell out of my way.
Okay, what happened?
Please tell me he's gonna be all right.
No, he dead.
Bugging, we just signed our first record deal.
Look, he dead, son. Ain't nothing we can do about it. Come on, Frank, that's it.
What do you mean he's dead?
He's not dead. It's a heroin overdose. Let's break out the Narcan.
He's dead unless you folks want to stop bullshitting me and tell it straight. Then the good Lord willing will try and bring him back.
Broke up with his old lady.
We didn't break up. We were just seeing other
she
people.
broke his heart.
Shut up, asshole!
Tell me
Nobody
to shut up.
asked you.
I was I talking to you?
Dick, I will. Shut up!
I'm still waiting and this young man here is still dead.
You want to leave him in a body bag too?
You end up like him.
Shut up.
Dick. Shut up.
He's been snorting that red death stuff. It's been going on for like 4 days now.
Rebuke the spirit of drugs in the name of Jesus. What's his name?
I be banging.
What you mean I be banging?
I be banging.
What the hell kind of name is I be banging?
I don't know his real name.
Frederick Smith.
Okay, Freddie.
It's Frederick.
Okay, I be banging. We're gonna bring you back from the dead. Now, I want everybody here to grab the hand of the person next to you. Come on now, we ain't got much time. And look up towards the heavens. Dear Lord, here I am again, asking one more chance for a sinner. Please, Lord, bring back I be banging, Lord. You have the power, Jesus. You have the might. You have the super light to spare this worthless man. Rise up,
Frederick!
I be banging,
Oh, my
and
God.
start your life anew, Lord. Oh, thank you, Lord.
What happened?
You fucking died, you stupid bastard. I warned you.
Damn, you guys are good.
Not us. The first step is love. The second is mercy.
Alright, so that's the case. The first step is love, the second is mercy. Alright, thank you, Ving Rames. Let's talk about opioids. Essentially, I bring this up as human decon. And if you know decon, rat poison, decon is actually basically warfarin, Coumadin, blood thinner that has many medicinal purposes. But in an overdose situation, it can be useful as a rat poison, and sometimes wonder if the opiates are kind of the same thing. Useful in many situations. Don't think that opioids themselves, Percocet, Norco, something like that. These things have uses, as much as people may try to deride them. But maybe if you take too much of it, then obviously it's a bad thing. And so I bring this up as it's almost like I wonder if some alien species out there has essentially figured this out and is trying to exterminate us. I will take off the tinfoil hat now and bring that analogy to a close. But the opioids themselves, let's talk about the opioids. Opioids act through the mu receptor. They act through a couple other receptors as well, but primarily through stimulation of the mu receptor. So they are an antagonist. Heroin is an opioid. It stimulates or gooses the mu receptor, and you get a response out of that receptor. The response is usually a feeling of pain control and initially a little bit of euphoria. And depending on the type of drug, it may last anywhere from 45 minutes to 2 hours to 23, 24, 25 hours, something like that, or possibly even longer, depending on the formulation and how you take it. Those are the basics behind the opioids themselves. As long as they are out there stimulating the mu receptor, you get the response that you normally think of with opiates, which is, yes, you feel better, there may be some euphoria with it, there's pain control, and at the same time there's probably some blunting of your respiratory drive and a little bit of respiratory depression as well, which in and of itself can actually be helpful in patients that can't breathe, and especially, say, hospice patients or folks with bad lung issues. Using opioids to help decrease that air hunger as they near the end of their life, that's a super great thing you can do for somebody. Even if they're not in pain, it helps relieve that dyspnea kind of feeling. So there's definitely benefits to it. Key point again, as long as you stimulate the mu receptor, then you get the effects of the receptor, and it's those things. So in terms of most of the illicit drugs, I was a relatively good kid. I grew up in a suburban neighborhood. I don't know that much about illicit drugs, so I had to learn some stuff on my own. This is how I always kind of assumed that you went out and got some drugs, if you wanted drugs of various kinds. But just to give you an idea, we're primarily going to be talking about heroin and with its the co-ingestants that people usually get with it is fentanyl. So heroin itself, what does heroin actually look like? We can sort of know about fentanyl because we use fentanyl pretty frequently. What about the heroin itself? How much do you take? What's it last for? Heroin is taken in a dose of about 10 milligrams-ish, 10 to 20 milligrams IV typically, or 15 to 20 if you snort it. The effects of heroin last for about 2 to 3 hours. It starts with that feeling of euphoria and then followed by the general feeling of pleasantness and being well, as well as the respiratory suppression. Most of the time, that respiratory suppression is most when you get that initial hit. Although it does not completely shut down your respiratory drive, it makes you less noticeable, or it makes it harder to notice that you need to ventilate primarily, and it takes out your respiratory drive. So again, the half-life is usually around 2 hours or so. The most dangerous part of that is probably in the first 15 to 20 minutes when you start to really get into trouble. That'll become important in a little bit here. So all the euphoria and the pleasant feelings and the blunting to the effects of hypercapnia and hypoxia seems like a really awesome thing. And of course, the problem with any of these drugs is that if you take too much of it, you get all the bad stuff that goes along with it. So what's the bad stuff that goes along with it? Of course, I've mentioned it a little bit before, untoward respiratory suppression. If you're trying to do it to keep somebody from breathing because they're under general anesthesia or moving because they're under general anesthesia or something like that, then that's an intended consequence. In most of our heroin users, they don't want that though. Or most of our opiate users, they're looking to get that euphoria effect without the respiratory suppression. And that's typically how it kills people. Other stuff that an overdose does, of course, CNS depression, which I kind of mentioned before, which you've all sort of seen. There's the potential to get pulmonary edema. One of the earliest things I remember as a medical student was going to the coroner's office. We had to go and watch an autopsy, so I was like 3 weeks into medical school, something like that. And the pathologist said this young man was brought in with a presumed opiate overdose. Here we're going to find out, here's a pathognomonic thing, and he sliced open the lung to section it and said, you see the water streaming out of this as he dumped out all this pulmonary edema essentially in this lung section. Said this is essentially pathognomonic for opiate overdose. So it is quite possible to get a significant amount of pulmonary edema with this. And then of course, as you suppress your CNS, you suppress your airway your airway reflexes, and so you increase the chances of getting something like aspiration. Or all the other bad stuff, obstruction of your airway, all the bad stuff that happens when you get CNS depression. And just to string this along, the most recent data, where are we at right now? I've talked about how things looked in 2007, 2012. Where are we at now? You see that the total number of drug deaths continues to rise on almost an exponential kind of curve. Synthetic opioids continue, they've made a comeback, and they have now become the primary killer of folks that die from drug overdose death. Prescribed opioids have sort of leveled off starting around 2010 when everybody stopped prescribing quite as much, and when a lot of states enacted bills that limited or made it harder to misuse prescription drugs. So we saw for a while, prescription drugs kind of leveled off. Heroin, this guy in the orange here, was climbing significantly, but it, in about 2015, was overtaken back by the synthetic opioids. What are the synthetic opioids? It's primarily fentanyl that's driving this. And that's primarily not so much that I'm injecting a bunch of fentanyl because I think that would be a good idea, but it's a co-ingestant or co-injection with something else, essentially a contaminant, a cheap contaminant that folks can use to provide less of, say, heroin or oxycodone or something like that. What does a drug overdose look like? Well, there's some pretty typical things about it. First of all, this is primarily a disease, not exclusively, but primarily a disease of middle-aged white men. So folks between the age of about 18 and 50, primarily, again, Caucasian males. That's not to say that nobody else overdoses, but this is the primary folks you see the highest prevalence in middle-aged Caucasian males. An overdose itself. What does it look like? How can you tell opiate overdose? We should all know this, but sometimes we seem to forget. So, altered mental status and somnolence, meaning not I'm up and I'm agitated and I'm running around, but I am sleeping or comatose, respiratory depression, and meiosis. Now, if you combine those three things, somnolence, respiratory depression, and meiosis, pinpoint pupils, that's somewhere around 90% sensitive for opioid overdose, but only about 70% specific. So yes, you can have other stuff that happens as a result of those three things. But if you see those three things, those are the primary things that you're going to see in a opiate overdose. You can also get, as I mentioned at the bottom, non-cardiogenic pulmonary edema, and also some element of bronchospasm. So these folks may have some wheezing. There's a good chance that both of those things are a result of just the respiratory depression for a prolonged length of time. But there's a little bit of effect from the drug itself. How do you actually die when you overdose on opioids? This is kind of an important thing to say. So a lot of us think that you inject, 2 minutes later you fall to the ground dead, you stop breathing, and you suffocate within about 5 minutes or so, something like that, just like anybody else that gets asphyxia. So we find people on the ground, needle still in their arm, and so they must have just passed out, and they're dead almost immediately. That's probably not actually the way that it happens. This is a sort of case example of it. So this is a gentleman that was put to death in Arizona, and whether or not you believe in death penalty is irrelevant here because I'm only using it as a medical case. So Joseph Rudolph Wood was given injections of Dilaudid, hydromorphone, and Versed, midazolam. He got a total of about 750 milligrams of each over the course of 2 hours. So initially started with a dose of 50 midazolam, 50 of fentanyl. 50 milligrams of midazolam, 50 milligrams of Dilaudid. Now, you would think that that would put down a horse, and it did make the patient, or make the, in this case, the prisoner, sleepy. But then witnesses said that he continued to sort of move around a little bit, and he developed this sort of sonorous respiration, things that made people think that he was gasping. Really what we probably found was that his respiratory drive was suppressed, and he continued to do what people who have a suppressed respiratory drive and decreased airway reflexes do, which is take breaths that sound like every now and then. And of course this is fairly distressing for folks, and they call this a botched execution. But maybe more importantly is he was redosed fairly frequently. And again, somewhere in the neighborhood of like 700 milligrams of each drug. And it still took about 2 hours for the gentleman to actually expire. Now, that is, again, under a controlled setting, and if you wanted to see what an opiate overdose looks like, it's not that he had that high a tolerance, it's that it takes a long time for somebody who gets an opiate overdose to actually die. What it probably starts as is you inject, and yes, you get almost immediate euphoria, you may get some respiratory depression, and you get the loss of airway reflexes. But once you hit the ground, your respiratory rate may drop to 10, but that's enough for most of us to sustain for some time. So even with a respiratory rate of 10, you start with initially a good SAT and a reasonable CO2. As time goes on, as you sit with that respiratory rate of 10 for 10, 15, 20 minutes, your CO2 starts to climb. And your SAT probably stays about the same. It's probably good at that point. As you continue to become hypercarbic, you lose the ability to self-rescue even more, which if you think about somebody who has a CO2 of 100, they're pretty wacky to start off with. And this is somebody who's not only opiate overdose to start with, now their CO2 is super high, and they lose the ability to sort of get themselves out of this situation. they probably maintain their sat for a decently long time. It becomes primarily probably a ventilation problem. Eventually, you start to desaturate as your CO2 climbs astronomically high and your respiratory rate continues to fall more and more, and then at some point, yes, you actually expire, but that's probably somewhere between 45 minutes and an hour after you inject, and it's a combination of that decreased respiratory drive, our inability to self-rescue, and then eventually hypoxia or severe respiratory acidosis, which causes VF. So obviously not everybody who uses drugs overdoses every time. Now the opioid overdose rate for drug users is really high, probably 60-70%, something like that, over your lifetime for long-term users. Folks get really good at knowing exactly how much drug to use at any given time. And this sort of makes sense. Why does somebody overdose? Well, it's probably not that they tried to use too much, because most of these guys don't want to die, they just want to get high. But also, heroin and other drugs are expensive, they're hard to get, and you don't want to waste it. You just want to give yourself enough to get high or to feel better, not so much that you die. So what gives? Why would somebody who's pretty good at dosing this stuff suddenly have an overdose when they may have never had one before and have been using this amount, they think, for a while? Well, there's a couple of reasons. One is that the heroin that you get is typically not made up in laboratory conditions. If it's manufactured in relatively clean conditions, somebody still has to get it and distribute it. And when they distribute it, they often will take a more pure product and cut it with anything they can find. So it could be flour, it could be baking soda, it could be dog food. There's many reports of things like scopolamine getting mixed in with your fentanyl. So there can be a lot of contaminants to it, and keep in mind that the guy that's putting this together probably is doing it in his kitchen, not the most savory of places, and certainly doesn't have the QC that most chemical companies or drug companies do. Another option may be that the person hasn't used drugs in a while. So the most dangerous time for a person who is a user is about the 2 weeks after they get out of prison or after they get out of rehab. About those 2 weeks, that's the most dangerous time in a drug user's life, because they tend to have lost the tolerance to respiratory depression, but they have not lost the tolerance to euphoria. And so you have a much more respiratory suppressive effect than you do a euphoric effect, and even the same dose that you were taking previously may now cause a significantly worse side effect, or may cause an overdose. And I mentioned the just got out of jail stuff. There was a couple of cases where you would say, what happened, or why this person overdosed. I said, I thought I was okay to drive. One of the folks that we actually talked to said, who overdosed on the side of the road, like as they were driving down their car, they said that they got in their car and then started driving. I said, why would you do that? You know that you might overdose. And the guy says, yeah, that's the point, because if I overdose while I'm driving my car, if I take it and then I overdose while I'm driving my car down the road, then somebody is going to see it and they're going to help me. And like, well, that actually makes a lot of sense. Okay, it's not a good idea, but it does make a lot of sense. And then again, sometimes what you find is that the quality control on this stuff is not great. So you may get an impure product on your first injection, say, man, this heroin's crap, and then do another one that actually has a little bit more, has a higher grain to it, and then overdose as a result of that. So the reasons for opiate overdose are many, but probably some of the primary ones are, number one, contaminants, because who knows what you're putting into this stuff, and then you're injecting it into their body. That just sounds dumb. But also, again, the most dangerous time in a drug user's life, first 2 weeks out of jail or out of rehab. Now, it's worth noting that there are many reports that say, law enforcement, sheriff's deputy, officer exposed to fentanyl, he was given naloxone by his partners, and they made a miraculous recovery, and now he's doing okay. This has come up in the last couple of years and is almost ubiquitous now. Some person says that they were assisting somebody who had an overdose, and they started to feel symptoms, and so they got some naloxone, and then sometimes they'll even say they passed out. And it had to be that they absorbed some fentanyl through their skin, or they absorbed some heroin through their skin, and this is a terrible thing. And almost certainly this is not what happened. I will just go ahead and make the statement that essentially all of the cases that I have read where somebody says, I was exposed to something and they got naloxone, they didn't have the symptoms of an opiate overdose. They felt funny. or they felt their heart rate going fast, or they got nauseous or something like that. There's nobody that actually had the respiratory depression, the somnolence, the stuff that happens when you overdose on opiates. There's just nobody that reports that. These are all some other thing. So it could be, yes, you got exposed to something in the back of the ambulance, or maybe the carbon monoxide was too high in that area, or maybe there was something else going on. Or maybe you use something ahead of time. There are certainly folks in EMS and law enforcement that are using these things themselves. I'm not saying that's necessarily what happened, but I can tell you that they didn't absorb fentanyl through their skin. None of these guys that are reporting had an overdose caused by a cutaneous exposure. And if you don't believe me, then look at the American College of Medical Toxicology, which basically says it is almost impossible to absorb enough fentanyl to cause an overdose through your skin. At least under normal circumstances. You don't need to wear a Tyvek coat or a Tyvek suit to go in. You don't need to wear an N95 mask for your commonplace drug overdose. Even if the person had it on their skin, the rate of absorption of these opiates is so low that you would have to cover your palms in fentanyl patches, which are specifically designed to get fentanyl into your body. You would have to cover your palms with those entirely, and then wait about 14 minutes with that in contact to get 100 micrograms of fentanyl. And 100 micrograms of fentanyl is a standard dose that's not an overdose-y type dose in the hospital. We give people 100 micrograms of fentanyl all the time. So, the chance that you are able to absorb enough free drug from something floating out there because you got a little powder on your skin, or you touched a patient who previously had touched some fentanyl, that's essentially ridiculous. There may be some mass hysteria going on. It's probably psychosomatic or highly suggested, but it's not as a result of the actual drug itself. And while I'm on that soapbox, one last thing. It doesn't make any sense, because if it was that easy to get drugs into your body, then you wouldn't have to inject it. You wouldn't have to snort it. We wouldn't have any problems. You would just take your fentanyl, you'd lick your arm, get it a little bit wet, rub the fentanyl on there, and sit and be high, and we wouldn't have this problem. So, yes, wear gloves, wear eye protection when you go out and take care of these folks, but it's not because you have to worry that you are going to overdose as a result of contacting these patients. It's just good practice.